Hello and welcome to HLA Live. This is the 6th episode of HLA Live, which is our weekly programme broadcast live on the HLA YouTube channel. Each week we talk to our interesting people from across the HLA community and beyond about the issues and topics that our community have expressed an interest in. The HLA has 6 pillars of leadership that we deliver our programmes on. The leader is a communicator, the leader is a manager, the leader is a negotiator, the leader is an innovator and entrepreneur, the leader is a follower, and the leader is a philosopher. Many of the episodes in HLA Live will cover one or more of these pillars. This week, we are talking about surgical lifestyles. This topic was a result of the work of Riddhi Shenoy and Alastair Coulson, 2 of our amazing scholars. This episode will be hosted by Riddhi and Alastair, who I'm handing over to now. Riddhi and Alastair.
Hello, I'm Alastair. I'm a final year Newcastle medical student and a scholar of the HLA. I'm very interested in surgery and I will be one of your hosts this evening.
Hello, my name is Riddhi and I'm an F1 in the Norfolk and Norwich Hospital. I'm doing an AFP next year, and just like Alastair, I'm interested in surgery and I'm an HLA scholar, and I'm also going to be your host this evening.
So welcome to the HLA Live episode on surgical lifestyles. We're thrilled to bring you our panel of incredible surgeons. So we'll start by introducing them. I'd like to first introduce Ms. Stella Vig. She's a trainer, NHS Champion, healthcare manager, and consultant surgeon. She's a winner of the Silver Scalpel for Excellence in Education, and she continues to advocate for diversity and inclusion. I'd also like to introduce Mr. Chris Hu. He is a plastic surgeon working in Belfast. He is a past chair of the BMA's North Island Junior Doctors Committee and a past committee member of PLASTA and ASiT. He has taught basic surgical skills and non-surgical aesthetics, as well as being an undergraduate examiner at Queen's University Belfast, selecting candidates for core surgical training. And next we have Mr. James Olivier. James is a registrar in general surgery at ST4 level. His interests lie in medical education, leadership and management. He was an HLA scholar and sits on several regional and national committees.
Also introducing Miss Roshana Median. Roshana is an orthopaedic registrar in South London who champions less than full-time working. She's worked in Washington, DC as a health technology specialist for the Department of International Trade and helped found the HLA alongside Johann. We have Dr. Sohaib Rafai. Sohaib is an NIHR doctoral fellow and a registrar in ophthalmology at the Great Ormond Street Hospital. He was recently awarded a grant worth £420,000 supporting his research in children with rare disease. We have Miss Kirstie Taylor, a registrar in plastic and reconstructive surgery. Kirstie has a keen interest in reconstructive surgery, hand surgery, and medical education. She is on the PLASTA UK Operations Committee. And last but not least, we have Simon Fleming. Simon is an orthopaedic registrar, a PhD candidate in medical education, and he also tries to change the world in his spare time. He is also president of the British Orthopaedic Trainees Association and has worked continually to promote the Hammer It Out campaign.
Okay, make sure you're subscribed to the HLA Live on Medics Academy and join the exclusive Slack channels to gain our panelists' insight into areas such as applying for surgical training and managing the challenges of a career in surgery. The links are in the description box below. A warm welcome to all our panelists. We're immensely grateful to you for joining us today to tell us about your work.
So going into the first question, how does working as a surgeon impact your physical health, mental health, and social well-being as compared to medical specialties? Open to the floor.
I'll start while everyone else ponders, because that way they can give better answers than me. I I think it's a tricky one because you asked us to compare it to our medical colleagues who work hard as hell. I think we have different challenges. So physically, if I'm honest, I find if I stand for too long, I get a bad back. Like, it's a proper old man complaint. But you know, if you're operating, there's quite a high rate of kind of back and spine problems in surgeons, because we tend to stand, and if your ergonomics aren't quite right, you can get back problems and shoulder problems and neck problems. As for the social well-being, I mean, the classic answer is that, and there've been debates on Twitter about it, that often people feel the need to stay beyond their hours to get surgical exposure, to chase cases and things like that. That's certainly a choice, and there are implications there for training, but that can eat into stuff. I've been on Twitter today following a lot of my colleagues who just started their core surgical training. A lot of them on day one have already had to go, I think I'm going to be late home, sort of thing. But to compare it to my medical colleagues, they stay just as late to take care of their patients and do their job. So, you know, it's the same challenges, but in a different room in the hospital often.
So I think there's a conversation of pre-COVID and post-COVID conversations of lifestyle. So medical colleagues, as Simon highlighted, work exceptionally long hours, and I think there isn't an easy speciality anymore in medicine. But I think the challenge in surgery is that if you're operating, you can't leave a case. You can hand over a medical problem. You can hand over a medical case, you know, on call. It's very difficult to do that when you're a surgical trainee, but also as a consultant, even though we work in teams, you have this loyalty and passion for the patient that you're looking after, and therefore you feel it should be around for them. But I think post-COVID, I think a lot of minds have changed, even in surgery, where we now, I've heard lots of colleagues now, and I'm much older than everybody on this call, but I'm hearing many colleagues now saying, actually, they've realized what a work-life balance is now, because during COVID, they couldn't work in the same way. And I think that will now have ramifications for surgical training, that I think some of our senior consultant colleagues now have realized what our junior colleagues have done, and life cannot stay the way that it has been. Roshana is a passionate champion of less than full time, and you don't have to do less than full time because you're pregnant and have had a child. You can do less than full time under flexible working for many reasons. So I think there are two clear conversations. One was pre-COVID, where I think life was very difficult. I think we're entering a new phase, and I hope that all the colleagues on the call today will recognise that we've got a real opportunity to change things, but it's still hard for every speciality. I'll hand back to you.
I'm going to chip in since you said my name, Stella.
Did it on purpose?
So, I mean, I could talk about this forever, and I won't because I'll bore you all to death. But I just wanted to maybe make a few points. So, physical was the first one I think you asked. I'm going to say some controversial things, which is not unlike me, but it's very common nowadays, certainly in orthopedics, in order to try and encourage women into orthopedics, we make light of the fact, you know, that people have historically said it's a very physical specialty, and you know that's why men do it, and this, that, and the other. I think it's important not to make light of it. Actually, it's not a barrier to women, but it's something that women should know about, and men, you know. But in terms of physicality, certainly in orthopedics, there is physicality to it. I personally find it exhausting. I'm not a, you know, I don't have much there, as you can see. So I do need to develop stamina. You know, I do do some training after I, you know, I've had babies and things, and I try and work up to it before I come back to work. And I do have physical problems as a result of my work. So, you know, I've got all sorts of things, like Simon said, back pain is one thing, but lots of other things. So I think it's really important to actually be honest with people, because if they're, you know, they don't know about these things, then they're not making informed decisions. So that's the physicality part of it. It is exhausting. It is heavy. It's orthopedics anyway, and it's good to know it when you choose that. And you can. It's not a barrier, you know. It's just something you need to know about. The second thing you asked was mental. I think that links to work-life balance. It links to a lot of things. I think it links to how good you are with risk, because operating, for me, certainly when I hold the scalpel and go to do an operation, certainly when I'm not 100% confident because I'm a trainee, is stressful. You know, it's a sort of stress. It's very difficult to explain until you're standing there yourself with a knife and you're about to do it. So you have to, I think, enjoy that sort of challenge, enjoy that sort of mental challenge, and it can be difficult, but it can also be exhilarating. So there's two sides to that. And I can't remember what the last one was, so I'll stop talking.
It was social well-being.
Social well-being. I'll let someone else talk about that.
Just before we cover social, I was just going to come in on to Roshana's point around the mental thing. Particularly in surgery, people talk a lot about the surgical personality. And the one thing we see a lot of in surgeons is there's a lot of perfectionism. You find it a lot, and actually surgery has quite a bit of burnout, quite a high rate of burnout. And burnout is primarily linked to a perfectionist attitude and fatigue. And we know that. And one of the things that Stella and Roshana have both alluded to is we've known that for a while, but it's only in recent months and years that we've gotten our head around the idea that maybe if we do a bit more work around kind of personal and professional well-being, work-life integration, not setting yourself on fire to keep other people warm, you actually do a lot better in the career. And there's a big piece to that, is just giving yourself a break, which is changing and is only a good thing.
So just to chime in on that sort of social and professional well-being, I think with what Simon was saying, I think a big part of that when you're starting out is having good insight into yourself and actually choosing the path that is going to suit you. Different surgical specialties, I think they're not homogenous at all. Roshana was alluding to the massive physicality of orthopedics. Plastics has a little bit of that, but significantly less than, you know, doing big hip and knee ops and things like that. So I don't have to worry about that so much. And I think that it's certainly, you know, looking in on yourself, knowing what type of person you are. I personally found the jobs that I did as a junior, which had the sickest patients, you know, the respiratory medicine, the, you know, big scary vascular surgery that Stella does. I can't take that. I find that really, really tough. And though plastics, we do have some life and limb threatening pathology, it's usually not every day, which I think suits me as a person better, and therefore means my general well-being and level of stress is better handled because of the choices that I've made into what path I've taken. I do agree as well, though, with the point that Simon made at the beginning in terms of, you know, comparing with our medical specialist colleagues. Actually, being a doctor in general, we all know, comes with the fact that you're going to have, not every weekend you're going to get to spend with your friends and family, and you're going to have long days and long nights. But if you love it, it's kind of, those things are, you know, don't matter so much, and you just have to know that that's what you're letting yourself in for. And obviously, surgeon specific, you kind of do need to like early mornings, because there's a lot of those.
One thing I always tell the trainees is that surgery is that there's a lot of waiting around. We're not, one surgeon is no longer a lone island. You know, we don't work alone. You know, yes, there's the early mornings, but there's a lot of time in between, and you've got to be very while waiting for the people to put people to sleep. And especially in COVID times, there's so much waiting around, and people, you have to be. I think I always tell the trainees that you have to take the good and the bad, and sometimes when lists fall apart like today, one of my lists fell apart, and we ended early. And the trainee was looking at me and go like, "What do we do?" And we're like, "Just go home and enjoy." And you have give and take, and I suppose that is reflected in a lot of medical specialties. But one other thing that always in our little unit in Belfast, I'm quite glad to say, is that we don't encourage presenteeism. Just because the list is not finished doesn't mean that you can't go home, especially if you have carrying responsibilities and so forth, especially as a trainee. And the consultant is different because you got to stick to the end because it's your patient and you got a sense of ownership, as Stella has attributed to. But very quickly to point out, and I think today a lot of the speakers have reflected the fact that there's a sense of a more increased insight into exactly what our working lives can be. And therefore we have to find adaptations. Personally, I find yes, health, physical, mental, social well-being. I can quickly summarize that in a free flap operation that could last anything from 6 hours to 12 hours. It is physically very exhausting, mentally incredibly exhausting. Even the 30 minutes just to concentrate on the microsurgery. And then my wife knows that if I'm doing my free flight cases, she doesn't expect me for dinner. If I do come back for dinner, then it's good. It's just being aware of what the specialty asks from you, and especially the subspecialty. And as everybody has said, carve some time out for yourself. That's one of the biggest mistakes I've made when I was training. I didn't carve enough time for myself or for my family. Thankfully, I've got more insight now. I'm trying to fix that.
I can try to answer this question from an ophthalmologist perspective. But first of all, I'd like to thank you so much for inviting me to be on this show with a panel of really inspiring role models from the other surgical specialties. Ophthalmology is a little bit different because it involves surgery as well as medicine. And the work-life balance is quite favorable. So in terms of the surgery, the procedures are quite short and day case, the vast majority. And also we operate sitting down, so that's nice. If you're after big action-packed operations, then maybe look elsewhere. But for short, delicate microsurgery, very precise surgery, then ophthalmology might be for you. You do need to be able to use both hands and both feet whilst operating. And the most common procedure is cataract surgery. This is the most commonly performed procedure in the UK and beyond. To answer your question in terms of physical and mental health, truthfully, I'm extremely privileged to say I would rate mine quite favorably at this point in time. And for social well-being, I get to spend quality time with family and friends. And I think this is because ophthalmology is very much sessional. The nature of the work is sessional, where your week is divided up into morning and afternoon sessions, and the on-calls are done from home. So we don't do shift working, twilights, night shifts, etc. When you're on call, you go home and take calls from home. And if there's an emergency, then you come in. Thank you.
James, I can see your hands up.
Yeah, I just wanted to say, partly a point that Stella raised actually about COVID times. I think we've learned a really good lesson about teamwork, particularly from our medical colleagues, actually integrating between intensive care, medical units, and just spreading the workforce. We've sort of regained an element of the firm structure. And whilst that may be temporary, I think we've got some important lessons about teamwork. And I think that's something that can be positive going forward in surgery, in that we're hopefully going to get more teamwork. We're spreading work amongst ourselves. We have advanced nurse practitioners and other aspects of the allied healthcare force which are going to join surgery, and I think it can only get better.
Thank you very much for your comments, and we appreciate what you said, and I think it's interesting in a panel like this one where you can compare the different experiences in different fields. One of the other questions that we want to ask you next that came out of the polling that we did for this event was this one. How can the surgical profession best support female surgeons to have the same chance for success as their male colleagues? Roshana, you talked a little bit about some of the challenges that are experienced by female surgeons. I wonder if you'd be happy to come in on this one first.
Where to start? My God. I could talk about this for days. I really could. And I'll make some points, but I can only really make it from my own point of view and the other people, other friends and colleagues I have who've spoken to me. So other people might feel very differently to me about this, or other people I've spoken to. One thing is encouraging women into surgery. So I think that's happening a lot more now. When I first started as a registrar, which was a long time ago, there were very few female registrars, certainly in orthopaedics. You know, even several years later now, there's more and more. So it is becoming more common. And I think as people have more and more role models, they might become more interested in joining surgery. So, encouragement into surgery is one thing, and providing role models that are accessible is another thing. One problem I found, even when I met female surgeons as a more junior doctor, was I would look at their lives, and this is not all of them, but the ones I had access to anyway, and I realised I didn't necessarily want that life. And what I mean by that is the two that I had access to didn't have children. And so that was quite a big thing, because that's what I was told all along. You know, you can do surgery, but having a family is difficult. So I actually remember speaking to a few people and saying, well, I'll start, and if I can't have a family, then I'll make that decision halfway through my training, and if I have to, I'll leave. It was kind of, and that's quite a painful decision to have to make. Like, why did I have to think like that in the first place? And that's because I didn't have role models who were the sort of adult, I suppose, or consultant or later trainee who had a family and had the sort of things I wanted. Luckily for me, when I got into training, it changed, and there were a few more role models I saw who did have families. I met Stella for one thing, and Stella is exactly the sort of person I hoped I should have met earlier on. It then becomes, what about when you're in training? And as I said, it might be completely different for different people. But for me, one of the big issues is expectation for women. So often I meet trainers or colleagues, not just trainers or consultants, who expect me to be the sort of woman that reflects the sort of man that goes for orthopedics. So I'm supposed to be an alpha, really driven, really competitive sort of woman. And actually, I don't want to be like that. I want to be relaxed. I want to enjoy my life. I want to enjoy my kids. I want to take my time. I want to be a good surgeon, but I'm not particularly academically competitive. I'm not competitive about other things. I just want to enjoy my job when I'm doing it. I want to prioritise my children, and those things are important for me. So I don't fit the mould that people expect surgeons to fit, or even some female surgeons. And that is one of the greatest challenges, I think. And that is what people come to me all the time. More junior doctors or even other registrars who are coming back from having kids come to me all the time and say, I don't want to be, gunning for it anymore. I want to prioritise my kids. I want to prioritise having a nice life with them and seeing them and doing this and that and the other that isn't surgery. I don't want that to have that attitude. And honestly, it sounds quite nuanced, but I think that's the biggest barrier to women, is that we don't want to have to feel ascribed to a certain personality type and a certain drive well, I don't want to have that sort of drive. I want to do it how I want to do it. And you can do that in different sorts of medicine, but for some reason in orthopedics you have to be some sort of kind of bulldog. And for me, it's getting the understanding and balance right amongst colleagues, trainers and deaneries that people can have different expectations of what the job entails and do it their way. Simple as that.
Thank you very much for sharing your experiences on that. Simon, I know you're somebody who has done a lot of work on culture change, and you're also an orthopaedic surgeon yourself. I wonder if you'd be happy to chime in and give some of your thoughts on this area as well.
So it is beholden to me to recognise my privilege in that I am a straight, white, public school educated, rugby playing bloke. And so my privilege has allowed certain bits of my life to be a lot easier than a lot of other sectors of the world. It just is what it is. But I like to stick to the Spider-Man principle, which is with great power comes great responsibility. So the question was about what the surgical community can do to facilitate more women coming into a career in surgery. And I think the most important thing someone can do who is trying to be an ally or an advocate is to shut up and listen, right? So the biggest problem, not just surgery, but the world has, is a bunch of old white guys primarily thinking they know what's best for people who aren't old white guys. And if you want to increase diversity, both of characteristics, but also of thought, both of which are vital to not become this stagnant echo chamber, whatever, you kind of have to just listen a lot more. And you have to accept that maybe the opinions you hold come from a place of privilege, but also sort of fear, because change is lost, right? So someone like Roshana saying, I don't want to do it your way, to a lot of people is like, well, why not? What are you saying about my way? What are you saying about me? What are you saying about the life I live and I choose and blah, blah, blah. And you kind of have to go, no, just, it's okay. No one's going to take your toys away from you. No one's going to, set fire to things you love, but it is possible to hold more than one idea in your head. You can do things more than one way. And we're seeing it in orthopedics. And I have to admit, I'm quite proud of the direction of travel. Certainly we see in orthopedics, but generally in surgery in general, we are slowly, and I mean slowly, getting the message that diversity is good for our patients, for our, for the public and for the profession. But the answer to a lot of it is to just listen a bit more. And then you have to go away and do that thing that surgeons do so well, which is reflect and go, I wonder why they said that. I wonder how I can help. I wonder what would be useful, not for me, but to help other people. And once you start to get your head around it, actually, a lot of these things become, for want of a better word, easier. But it's that first step, because if you go in as a, straight white bloke going, don't worry, women, I know the answer, by definition, you're just going to create another oppressive system, because you can't help yourself, because it's human nature to look out for, who you are and what you know. So the answer for the profession is to listen to the groups who are saying stuff to it and go, yeah, that's not a bad idea, actually. Maybe we could change a little bit to make a massive difference.
Thank you very much. Kirstie, I saw that you had your hand up. Oh, sorry, Kirstie.
Sorry, yes, I've unmuted. Yeah, so I just think, following on from both those points, it was great to listen to what both just had to say there, because I think from what Simon's saying about embracing diversity and kind of trying to combat these implicit biases that we might have in our systems, and through what Roshana was saying, I think absolutely flying the flag for what I think is the most important thing, which is visualizing female surgeons, putting them out there so we can see them, and the different types of female surgeons that we have there. We're not a homogenous group as women in surgery. We're all so different. And I think without a sort of direct visualization of these different wonderful women in surgery, it makes it a really difficult cognitive association to develop as to, you know, what is a woman in surgery. And that sort of, if you don't have that visualization, that just feeds implicit biases that people have. So I think having, you know, prominent female surgical role models like Roshana was saying, and women in positions of leadership in surgery is really vital. I too was really inspired by having Miss Vig as my training program director in my core training, you know, seeing that there is a woman who has a family and a fantastic career. That's so inspiring. I can see it, which means hopefully I can do it. I think it's why I myself have chosen to, in the past, speak at women in surgery events, because though it slightly sticks with me because I don't see myself as a woman in surgery, I'm a surgeon, but if even a little bit, me speaking to, you know, junior colleagues, male and female, if they can see me, a female surgeon, it maybe normalizes that concept and helps decrease biases, which I think can only be a good thing to increase that diversity in surgery, because exactly as Simon was saying, we need that. Our patients need different people. We don't want a uniform group of people, because that's not what humans are about.
Thank you very much. Ms. Vig, you've been described as an inspiration twice now. I wonder if you might be able to enrich us with some of your thoughts as well, please.
Thank you both, and all of you actually. So just want to talk to two things. So one is about women in surgery, and the second is about people in surgery. And I'm just going to pick up on points that people have made. So I'm just going to go back historic, okay? So I am really old. So in 1991, I qualified. And in 1991, I remember meeting Professor Avril Mansfield, who was the doyen of role modeling in, you know, the only woman in surgery. And as Roshana said, you know, I trained in Wales, and the only female surgeon above me was someone who told, I met her at a training evening, and she told the coarsest of jokes at the end of the day. She smoked a cigar, and I just remember thinking, I just do not want to be like you. I am not that individual. And then the next female surgeon I met was Professor Avril Mansfield. And it's interesting, Roshana, the first thing I asked her when I saw her was, can I have children and have a career as a surgeon? And her answer to me at that time was, I don't know, because I've adopted, I haven't had any of my own. And then I met a fantastic male role model, Kieran Horgan, who was my first consultant when I was a houseman. And I had made a decision between starting house officer jobs to the Christmas. I'd already made a decision to not do surgery because there were no female surgeons around. There wasn't a single female surgeon in Wales. And Kieran Horgan said to me, if you want to do it, go for it, reach for the stars and see what happens. And I'm really disappointed that we're still having these conversations, God knows how many years further on. So Simon says people need to shut up and listen. So people need to shut up and listen, but people also need to stop people making stupid comments. So if anyone in my presence ever says that women can't do surgery, or Roshana, I take the point about physicality, but actually you can learn and adapt if that's what you want to do, or you choose the specialism path that suits what you want to do. Work-life balance is as you wish to make it. I was told within 3 weeks of starting as a houseman that I would burn myself out. I haven't burnt myself out. It's the way I choose to live. I thrive on it. Other people won't. I have 2 children. I was told not to have them until I had a consultant. And twice I went to my husband and went, oops, just need to let you know something. I've told that story before. So you need to make your own way through this. And all I can say to women who wish to do it, you need to go into it with open eyes. There are plenty of us to support you, male and female, to do this. The old adage was that, you know, I've had 2 children, and with both of them, I had 12 weeks off with both my children. No woman anywhere near me in any way, shape or form will ever take 12 weeks off post-surgery. Roshana's laughing because I've had the conversation with her. You know, you take a year out, it makes no difference at all. You've got a lifetime career as a surgeon. If you're coming back, you make a choice how you come back. Do you come back less than full time? Doesn't make any difference. Once you qualified, no one knows what you did. Once you've qualified, you choose whether you work full-time, less than full-time. The biggest difference that will be made to get women into surgery is actually understanding that less than full-time is normality and not an exception. And there needs to be funding that goes with it. Because a number of my colleagues, even in my own hospital, who say, we're not taking a full-time trainee because how are we going to manage the rest of the service? That's not even a conversation anymore. But the other bit for me is this is not about women in surgery. Kirstie, I have to say loud and clear what you said. There are women in surgery, but there are women who have children, there are women who don't want to have children. There are women who want to play sports, there are women who don't want to play rugby and hate it, like me. I don't hate rugby, I'm Welsh, but I don't want to go to a rugby match. So, but there is a conversation. Roshana, you talk about the surgical personality. Simon, surgical personalities. There are plenty of men who do not fit that surgical personality. And a man, it doesn't matter what colour you are, is not going to go into surgery and actually play up that old model of being a surgeon. There are plenty of gentlemen who have gone into surgery who are kind and compassionate and leaders, and they're the people I want as my consultant colleagues. So the answer for me is, you know, women in surgery, yes, do you know what, if you want to do it, come and find any of us and we will support you to do what you want. And it's not about finding a female role model. Find someone who will support you. Ignore the people who tell you that women shouldn't do surgery. Absolutely ignore them, report them to one of us, especially to Simon, who will hammer it out of them very, very quickly. But remember, this is about people in surgery, and everybody needs a work-life balance and needs to be able to do what they want to do with their career. I'll come off my soapbox now and hand you back to you.
Thank you very much for that. I am looking out now. Is there anybody who would like to come in at this point on this question?
I would like to come in.
Save.
Thank you. I want to just make 2 points, picking up on Stella's point, which she's made very eloquently. We all have a duty to call out everyday sexism in the workplace, okay? Not just in the workplace, but outside the workplace too. We all have a duty. We need to support the women around us. That's number one. Number two, it's very powerful to see people, inspiring role models in the field where they resemble your background, so you can visualize yourself in that position. That doesn't just apply for gender, but across the board. It's very powerful. And so it's fantastic that on this panel, there are 3 inspiring female surgeons. This should be encouraged and this should be celebrated.
Thank you very much. And that's given us a perfect segue into the next question. So I will hand over the floor to Riddhi to answer.
Thank you. I think we've heard so much about how we're trying to encourage diversity in the surgical profession and combating those systemic biases that we have towards diversity. And my question to you is now, what do you think we can do to make surgical specialties more inclusive to not just women, but BAME staff, LGBTQ staff, and also less than full-time workers across the board? Would anybody like to take this first?
I can speak about less than full time just quickly.
Thank you, Roshana.
Because I'm doing it. So I started less than full time training after I had my first child. I've got 2. And I did that because I wanted to spend time with them, was one thing. And 2, because I just wanted a nicer lifestyle as well, which I think a lot of current medics and surgeons will possibly agree with me is an ambition for many of us. So I have to say it's been interesting. I have been the first less than full-time trainee in my deanery. This is what they've told me. And obviously it's orthopedics, so there's fewer women also. It's been interesting because what I found essentially is that they've got no clue how it works. And that's possibly because I'm the first one. So I've had to lead a lot of the discussions and make sure things are being done properly, go between the BMA and them and just check, rotas are right, check the guidance and whether they're following the guidance appropriately. They have actually been very good in lots of ways, allowing me to design my own rota, as long as it meets the service needs where possible, and my training needs. They've always treated me with respect from the HR sort of aspect. And my consultants who I've worked with have been very helpful. But there have been instances where there have been difficulties. So I have actually once been around the corner from some consultants talking about the fact that I was less than full time. And I won't go into what they said, but it was the sort of thing you'd imagine from back in the day. So those attitudes still exist in surgery, and it's a shame because I speak to my male colleagues and they would love to be less than full time for the same reason. They want to spend time with their children. So it's not just women, it's all sorts of people, whether it's for parenting reasons or because you have other interests or you want a bit of a better work-life balance. I think the first thing that needs to change is attitudes. Like I said, I shouldn't have to hear something around the corner that's unpleasant. So attitudes and education around why less than full time is important. The second thing is increasing the availability. This idea that you need a specific reason to go less than full time just needs to end, and it has done in lots of specialties like emergency medicine. But I think that should be rolled out throughout surgery, and I think there are plans to do that. Stella and Simon might correct me. And the other thing is to help less than full-time trainees realise the cases that they need, and obviously that's all around rota design. And I think as people get more experience, that's going to become easier. So I think there are several things we can do to help less than full-time trainees and encouraging people into it if that's what they need or want. And I think it's a very good thing. I'd recommend it. I'll let others talk about the other points.
Simon, I can see your hand up.
I'm going to do my my making friends routine. So the systems we currently work in are inherently racist, sexist, and homophobic. It's not really a debate. We know it to be true. We have evidence of it. And I think part of the way that we will overcome the bigger issues around making surgery a more attractive prospect and more accessible to all characteristics and groups is to try and challenge those issues as well. So there's sort of the, if you like, the grassroots aspects, which Roshana really eloquently touched on, right? People just not knowing that less than full-time is a thing, or raising their eyebrows when someone suggests that they might want to have, work an 80% rota or what have you. But, we know that there is differential attainment at the MRCS exam, and we know that there is differential attainment at the MRCS exam, including in the exams, the bits of the exam that are marked by a computer, which means that we are failing those people long before they get to the exam. It's not someone looking at someone and going, goodness, you don't look like me, I'm not going to give you the same mark. We are letting them down at medical school, at work, we're letting them down throughout the system. We are failing them, we are not supporting them in the correct way. And I think that's why these questions are so scary to people, because as recent events around Med Bikini and Black Lives Matter have shown, there is a systemic issue with attitudes towards virtually all characteristics that aren't, again, straight white men. And we have evidence to support that from the NHS staff survey, from the GMC survey, and from the work done by the colleges around this sort of stuff. And I think the answer with any kind of systems change is, A, we need to start early. We need to start changing the way we deal with medical school, the way we represent surgery at medical school, because you can't be what you can't see. So medical school need to meet surgeons who aren't old white guys. They need to meet those role models early. And I think, without sounding too much like one of my gastroenterology colleagues, we need a top-down, bottom-up approach. So we need to be changing the way our leadership look. We need to be changing the way our organizations look and are led. We need every panel to be diverse, every committee to be diverse, every organization to be diverse. And simultaneously, we need to work at attracting people in at the ground floor. At a kind of F2 core level, we need to be saying, come be a surgeon. This is why it's awesome. And it can be for you, and you're not going to be treated any differently. Because, and I say this, and again, it is from a place of privilege, but still, I don't fit in orthopedics. I do qualitative med-ed research and culture change. And so I don't fit into a lot of circles where I look like I should, because I look like an arthroplasty surgeon, but I want to be a hand surgeon. And I was taken to one side once and told, hand surgery is a bit like pediatrics, it's for women, really. And I was like, what? And so there's this nuance of actually us having to change inherently the systems that currently exist at nearly every level. It will take time to do the big stuff, but we can do the little stuff easy and early.
Thank you so much. Thank you. I think it's really interesting. It's the sort of comparison between, I think we're preaching to the choir here when we're talking about trying to include more and more diverse people in surgery. And it seems to me that the higher levels of leadership that we're trying to include diversity in often are the, perhaps, I correct me if I'm wrong, but it does sound like they are the kind of people that already do fit the surgical stereotype and perhaps are biased against the people that we're trying to include. So I don't know if you would agree with that or what your views are on that. I know it doesn't sound like it's going to happen overnight, but would anybody like to elaborate on that?
Can I maybe, sorry to veer off that particular topic, but one thing I want to say is that a lot of people think that it has to be top down. What can I do as a junior, and so forth. And one thing I must admit, I haven't done as much as I had in the past, but I'm trying to do more and encourage more, is don't walk past the comment. Just because you're a junior doesn't mean that you can't stand up for your other friends and so forth. If you are in a position of privilege, do you fit that role model where you are a straight white guy who plays rugby or whatever in orthopedics or whatever? You know, if you fit that role model and you hear a comment and that says, they say like, oh my God, I literally heard this comment about a couple of weeks ago about my very good friend and colleague, Kira McGoldrick, who's a fantastic plastic surgeon, microsurgeon, and she goes like, oh, you work with Kira? Oh my goodness, you better not cross her, if not she'll do something to your lads, you know. And then the two of them were laughing, and I go like, excuse me, you're talking about my colleague, and that's not very nice. You shouldn't say that. She's a very hardworking person, and she's very determined, you know, and she's a very nice person. Okay, and then some juniors might say to me, oh, but Chris, I can't really say that to my boss, you know. Then say it to your mates if they say it to you. If you don't walk, the standard you walk past is the standard you accept. If you want to make a difference, even at your junior level, start with yourself and start with your mates. If your mates are starting to, heckle, you're like, she's quite a looker, that girl, she'll never make it in orthopedics or surgery or general surgery or lower GI or whatever. Just say, excuse me, I don't think we should objectify our colleagues. You should not walk past that standard, and you should say something. And that's something any junior can do.
Stella, I can see you have your hand raised.
So we've recently, I'm also a member of the College of Surgeons, council member. And I'm not sure how many of you are aware, but it's very visible that at the recent vice president and president elections, we appointed 4 people now, who actually look very similar and don't represent the diversity of surgery that I see around me, especially working in Croydon. And it's interesting, it sparked an interesting debate, and it's a debate I've not heard at council ever. in the time that I've been there. And this was, should we have a vote that puts a female vice president in post? And the conversation was that that's not the conversation. That the conversation of putting a token, you know, coloured female into a post is not the right conversation. We need to be getting there by merit, because that's what people think should happen. But this is, as Simon says, this is more not about females. This is about absolute diversity in surgery. This is not about equity. This is about inclusion. So this is not whether women should do surgery, not whether you know, have a different sexual preference that you can or can't do surgery. The comments around that's just not modern day society. But modern day society, as Simon also eloquently says, is absolutely biased against a certain sector, and it promotes a different sector. So, as Chris says, calling it out every time, ensuring that the opportunities are there, but actually listening to what happens, especially at my level as a senior consultant. What I do and what I say is held by many people. So if I decide to join in the banter that's going on in the surgical coffee room, that's an acceptable behaviour, and it sets the chain of events. Well, it's not acceptable behaviour. It's not acceptable behaviour that, you know, Roshana heard a conversation about her around the corner, and that is being replicated in every hospital, every trust, even at medical school. There are conversations happening about intelligence or the ability to carry on a career, or, you know, people don't understand that behind every individual there is a family. You don't know whether people have constraints at home or carer responsibilities or something else that stops them doing what they want to do. But two things have happened. One is the HE review on flexibility and less than full-time working. Even in surgery now, Roshana, it's not restricted. So if you want to go less than full-time, you go less than full-time. You do not have to give an excuse, a reason why, not an excuse, a reason why. Because if you decide you want to open a business and you want to be an entrepreneur, do you know what? You will get my support to go less than full-time. The other conversation is a really important conversation, which is the Royal College of Surgeons of England now have got an inquiry and a commission that is going to look into equity, diversity and inclusion, chaired independently by it's Baroness Helena Kennedy, who's a prominent lawyer. And I'm really looking forward to the review outcomes. But the question for the review is not whether women should be in a different place. It's about diversity, equity and inclusion across surgery. And I think when we get leadership from the top, recognizing and wanting to make a difference, and as Chris says, it joins up with the grassroots. Every single hospital needs to stand up, and I keep quoting Simon because he's amazing. You know, that stand up and hammer it out, call it out. It's really, really important. I'll hand back to both of you.
Thank you so much. Thank you so much for your insights. And I think they've been really inspiring to people like me and Alastair, and hopefully our audience who's watching, who are at the very start of our careers. It can be so easy to fall into the norm of what we see in our departments when we're working there. And it's really reassuring to hear from you. You know, it really validates what we feel and how we believe we should act. So Alastair, I think we have some more questions to move on more about the actual work.
Yeah, absolutely. And I'd like to echo Riddhi's comments on that as well. I've got a question now that might come across as a little bit negative, but as I say, this was a question that medical students and other people responding to our polls were really interested to hear the answer to. And that is, in just one sentence, can you please tell us what you consider to be the most stressful part of your job? Now, if you don't mind, I'd like to start with Sahib on this, because you've talked about your job having a nice balance of things. So I'll let you take this away if that's okay. And I intend to go around everyone if that's okay. So put your thinking cap on.
Sure, I'll try and keep it brief. No two specialties are the same, and every specialty has its own rewards and challenges. In ophthalmology, the biggest challenge is the volume. So the high volume in terms of surgical caseload, laser lists, injection lists, and the clinics. If any of you walk into an ophthalmology department at sort of any given time, it's so busy, it resembles an airport departure lounge. You will see 100+ patients at any time. So time management is very, very important in order to survive in this specialty.
Thank you very much for that. And I'm just going to go across my screen now. So I'd like to come to Simon Fleming now, please, if that's okay.
It's interesting when I think about what the most stressful bit is. If I'm honest, it comes down to kind of continuously being assessed. I'm not very good at giving myself a break. I recognize this. I have to work very hard at giving myself a break. So I'm continuously aware that one of the best things about orthopedics is we have x-rays. We have meetings every morning. Everyone knows what you've done, what you've seen, what you've said, the decisions you've made. And I have worked very hard over my very, very, very long career as a trainee to get better at making mistakes and learning from them, because orthopedics has a real culture of scrutiny and not self-criticism, but kind of really holding yourself to account. And so if you're going to hold yourself to account, you have to find a way of normalizing making mistakes and having a coping mechanism for that, so that it's one of my old bosses used to say, feedback is the breakfast of champions. But I kind of love that, but it took me a while to get used to that, and it still from time to time is tough if you get a lot of feedback for breakfast.
Thank you. James, I'd like to come to you next.
Sure. So for me, actually, thinking about it, it's probably not the operating or the endoscopy or clinics or anything like that. And whilst I'm a junior surgeon on ST4 going to ST5, for me it's the non-specific aspects of work that aren't to do with surgery. So things like conflict with colleagues, or that same sort of aspect with managers. And I was really inspired by the HLA episode 4 previously, with Geeth's respecting powers and Chris Turner's civility saves lives. And I think whilst what's stressful for me isn't specific surgery, it's generic for a trainee or a doctor or healthcare worker, I think this is a conversation people are having, and it's going to get better in the future.
Thank you very much. Can I now move to Stella, please?
I'm hoping I'm unmuted. Yes, I am. I think there's two areas of stress. It's interesting. So I'm consultant vascular general surgeon. I educate, but also I'm clinical director or divisional director for the hospital. And more recently, I've now become the director or the clinical director for recovery. And that's getting all our services back on site. And I think the most stressful thing for me is that balance of ensuring that trainees get trained and there's education, but also we're delivering the service that we need to do. And in that is that difficult role that I think you develop as you become more senior in management, where you're expected to toe the line, and actually disruption actually changes things. If we carry on doing the same as we've done before, nothing changes. And they talk about the NHS being a big ship. Well, you have to put a bomb under it to make it move. And so I think that's quite stressful, because you have to be careful of what you do, but you know what's right to do and you have to do what's right. So that's one part. Second part is interesting. I've got now a 23-year-old and a 22-year-old. 22-year-old is now a final year vet, but has no vet placements and is going to qualify at Christmas, and is really stressed about how he's going to perform as a vet when he's had no experience. And my older one, who's 23, finished from Oxford, is now doing his law conversion, trying to get pupillages, and there are new pupillages, and both of them are going to go into an environment now where I'm not sure what's happening in the employment sector. And I don't know what they're going to have as long-term sustainable green planet that we live on. And I think for me, there are two bits of stress. As I get older, and I'm told once I have grandchildren, I'll get even more fraught about it, is what life do they have, and what's the legacy I'm leaving for them? And I think those are the two bits of stress for me.
Thank you very much for your perspective on that. Can I now move to Kirstie on this question, please?
Sure, gosh, my stresses, I think, pale into insignificance with things like thinking about the state of the planet moving forward. But probably my biggest stress over the last few years as a surgical trainee is that of geography. So where do you live? And where, particularly with plastics, with huge deaneries, the trying to work out where you live thing is really difficult. So I've had non-medical friends and also friends in other specialties, non-surgical specialties, who've been able to set up home, and I have not yet, but hopefully that'll change soon. Granted, I've also not made it easy on myself because I have another half who's also a surgeon in a different specialty, which just makes it more difficult. So I'd advise against that if you possibly can. But yeah, the geography's tough, the moving around to try and get the best training, but that can be difficult to balance.
Thank you very much, and some good advice there as well. Can I move to Chris Hu now, please?
I've just started my consultancy in the last year or two, and I must admit that as a new consultant, and the most stressful part of my job at the moment is being actually, ironically, responsible for people, patients. I always tell and worse still, I jumped into private practice very early, and I remember the most stressful case I've had. My first case where my name's on top, Chris Hu, responsible consultant. I was in the private sector, which is even lonelier. Was a very complex operation. It was an excision of a sebaceous cyst right here, and I was crapping myself when I had my knife close to the sebaceous cyst, and I got, oh my God, it's just me. There's no one else. That was particularly stressful. I'm quite glad to say now that I've got a few more months under my belt, I'm getting better at that, but I'm still incredibly stressed out for making decisions that I understand that patients have most of the time. I know this in modern day about joint decision making between patients, but they're still very paternal. And they ask you, especially my cancer patients, they ask you, what do you think, doctor? What's best for me? And suddenly you realize how much of a vulnerable position those poor patients are. And you are trying your very best to decide for them. And sometimes they leave decisions with you. And I find that most stressful. But the antidote to that is having really good mates. I mentioned Kira, but I've also got other friends like Punja Sharma and so forth, who I can pick up the phone to and go like, oh my God, I think I just killed someone. Or not killed someone. I've just totally destroyed my surgical career by doing something stupid. And they talk me down. They go like, Chris, don't be stupid. You've made the right decision. It'll be okay. And so forth. And I provide the same service to them. I like to think not as often, but so as a starting out consultant, anybody who's coming towards the end of your training, have really good mates that you can pick up the phone to at any point, any time, and just say the stupidest things to them, because they'll be your lifeboat. And surround yourself with good mates. Have a very, very select phone numbers.
Thank you very much for that. That's a great message as well. Can I finally move to Roshana as well, please, for this?
I'm trying really hard to think of one thing, but I think like Stella, it's got to be two. One is training the kids, because you, as I said before, you want to be there for them. You want to get back in time for them. You want to be able to see them, at least once or twice a week. That'd be nice. So not only being able to spend time with them and the stresses of looking after them and things like that, but also the feeling, like Stella said, of being a role model to them, being responsible, showing them what working hard is, and not working too hard, you know, so that responsibility goes both ways. So being a role model to them is I wouldn't say it's a stress, but it's always at the forefront of my mind, you know, and looking after them. So if I were to separate the kids part, the other one would be my constant frustration at the indoctrination and rigidity of medicine in general. And I find it incredibly frustrating, and I think partly I find it even more frustrating than most people because I've worked outside of medicine, and I honestly believe medicine to be one of the most rigid, immovable, as Stella was alluding to, painfully hierarchical, and many other words that you could think of, type of career. And I'm frequently frustrated at many different things. And the best thing I ever did, and you know, as I said, works for me, might not work for other people, best thing I ever did was marry a non-medic. Because those frustrations I can bounce off someone who lives in a completely different world to medicine and can say, that is ridiculous. You know, that would never happen to you outside of medicine. In my career, in these careers I've done or whatever, people wouldn't speak to you like that. People wouldn't do this, people wouldn't do that. And it's a great sounding board. You know, I can then go back and feel either that I've vented or that I have the right to go and say something when I think something's inappropriate, or gives me confidence to look at and explore things outside of medicine, which I do a lot of. So those would be my two stresses. One, the immovability and rigidity of medicine, and the other, obviously, for all parents, you know, wanting to do the best by their kids.
Thank you very much for that, and it's great to see such a mix of answers and how the stressful parts of your job change, I suppose, depending on where you are and depending on what stage you're at as well. I'll hand over to Riddhi now, who has another question.
Yeah, I just want to say thank you all. I mean, as someone, again, who's very sort of just starting out, you know, a career really, it's easy, you know, for medical school, for students and young doctors to look at surgeons as nothing but surgeons. We've only ever seen them in a surgical environment. We've only ever heard them talk about surgery, and I think we all do sort of think that all surgeons do is surgery and work. And I think it's really, really lovely to hear, well, obviously not lovely to hear all your stresses, but I think it's so good to hear that you've all got such different sort of perspectives and views. You know, we need our friends, we need somebody to bounce our frustrations off, we need to know where we're going to live. And I think it's been really good to hear the sort of broad view of all the challenges that you perceive. So thank you so much. And I'd like to continue on to asking you, does it get harder or easier to work as a surgeon? I mean, if we could perhaps start with Chris, you alluded before to the fact that, you know, as surgeons progress into consultants, you have more responsibility, you have to stay till the end, it's your patient. So perhaps you could tell us, Chris, a little bit more about whether you think it gets harder or easier to work as a surgeon and how the challenges change.
Okay, I'm one of those insufferable people who love work. I think it gets different. There's always a level of, I've never come to a point in my life where I'm going like, no, but there's nothing for me to do. I've reached my peak or plateaued. I like to think I'm not reached my peak yet anyway. And it just gets different. The challenges, the transition between trainee to consultancy is very, very different. You suddenly realize there's this absolute mountain of management and paperwork that you handle, and you actually operate very little compared to when you were a senior registrar and you were operating almost every day. It was really fun. And I think things just get different. And continuing on and I think that's the other thing. When you reach consultancy, it's not the end, it's just the beginning. And that I think we have to change the idea, because we'll spend many years in consultancy, I hope. and the role of a consultant changes as you grow more senior and so forth, as obviously evident by Stella's worries and differences in responsibilities. I don't think I'll ever reach that height, but there you go. And going on your question, how do you see the specialty evolving in the future? And I think especially in plastic surgery, plastic surgeons used to think as if they were God among gods, coming in and solving all the problems. I think the role is becoming, I think almost in all specialisms, especially cross specialties, there's a lot more teamwork. There's a lot more working together. I work with a lot of very good general surgeons, either breast surgeons or low GI surgeons and so forth, and help and combine cases. Even in our large free flaps, there's usually 2 consultants working together, even 3 sometimes, from another specialty and so forth. So teamwork is going to be a huge thing. And if you like to work alone, I'm sorry to say, you're not going to enjoy surgery. It's going to be a team sport from here on. I haven't even touched upon the other healthcare professionals, that the myriad healthcare professionals that help me do my work every single day, and in fact prop me up, if anything.
Thank you so much. And perhaps we could hear from James as perhaps a little bit more early on in your career. Could you tell us a little bit more about how you think it's going to get harder or easier, and how the challenges have been changing?
Yeah, definitely. I think different's a good way to put it. So far it's been both easier and harder. Even already I've noticed I'm starting to get better at pattern recognition in terms of seeing patients and working them up and treating them. And I'm hoping that will continue to get easier. And of course, with learning procedures in surgery, they start to become easier. And as they become easier, you get harder procedures, which is great. I think it's really important to continue pushing yourself and rather sort of sit on your laurels, continue pushing yourself to go to harder procedures, more difficult procedures, within reason, of course. So I think, to summarize, it gets harder and easier.
Thank you for that decisive answer. If I could also ask Kirstie the same question, you know, a little bit earlier on in your career, how do you feel about the challenges?
Yeah, of course. So I think my observations, both looking back to my core and foundation years and looking forward to hopefully being just like Chris, kind of match what he was saying, which is that I think it becomes different. So very much the early years, I think, are about your theory, taking your exams, get your knowledge in. So for any kind of more junior people watching now, work on that stuff. It's really important. It will continue to see you through. Then obviously I feel I'm in the sort of zone at the moment where it's gaining your operative skills and progressing to that independence and autonomy of operating, doing lots more operations by myself, running trauma lists myself, that kind of thing, which is, you know, I think sort of to echo what James was saying, it's easier in a way because it's way more fun to be doing the operating bit than doing the exams bit, I think. So, but it's tough, you know, learning. The operations get more and more difficult, but it's great fun. And then I think sort of looking forward, I think the next bit that will be happening, obviously I've got lots more skills and lots more autonomy to gain, but it's then that increasing level of responsibility in becoming a consultant. So I've tried to take on some of that during being a registrar. Actually, I do take ownership of my patients. I make sure I go and see my postdocs personally. I try and review my patients myself in the clinic if I possibly can. It doesn't always work like that because that's not necessarily how the system works. But if I can, you know, when I've got a little local flat that's coming in that I did the week previously, I know when their dressings clinic appointment is because I schedule to go and see them because I'm starting to want to take responsibility for my patients. And I think I'll just get more and more of that, but it obviously gets more scary when it's just you and the buck stops with you. And then I think probably the next challenges after that are taking on those management and leadership roles. Yeah, that's sort of, you again, I think you start doing that in your training, and I think it's brilliant that you've got things like the HLA and you've got, you know, you start thinking about being involved in how things are managed and being leaders right from the start, because actually that's so important all the way through. It doesn't just happen at the end. it's very much a kind of fluid spectrum, I think.
Thank you so much. And maybe Stella, if you could talk a little bit to us about how you've been finding, how did you sort of get into the sort of other roles that you've taken on, as well as being a vascular surgeon?
So I think Chris has got it spot on, and I'm going to go back to what Johann said at the very beginning. So you look at the definition of a surgeon is not just someone who operates. A surgeon should be, from the very beginning, the leader, the trainer, the innovator, all of those. It's like, you know, the sound machines where you're doing a sound check and you've got levels going up and down. Those levels need to be going up and down all the way through your career. There are some things surgically, there is, I'm going to touch wood because I'm going to be on call again, but surgically there's not much that comes through the door that I think I can't manage. And if there is, I know who to call, and I've got the best friend to call when I get myself into trouble. So I think, you know, the surgical side is one, but then you've got the education and the learning and everything else that goes. So it is different, and you invest your time differently as time goes on. But the other thing to consider for everyone who's on this call, who is much, much younger than me, when I started training, the things that you are doing now, oh my God, when I started training, guys, we weren't allowed to order a CT scan. MRI scans developed in my lifetime. How old does that make me sound? But the things that you will be doing in your lifetimes, the people who have medical schools now, so, you know, Alastair, the things that you will be doing as surgeons when you get to the middle of your career, top end of your career, you might be doing the Star Trek healing from the outside. God knows what you'll be doing. If you think that when we started, Johann and I are, he's nowhere near as old as I am, but, you know, when we started, Google wasn't there. The internet wasn't there. You know, all these things, the jobs, you know, the CEO of Google, that person didn't wake up thinking, I want to be the CEO of Google. It just a job that developed in their lifetime. So please don't start worrying about how hard or difficult this is going to be. Just enjoy the journey of being a surgeon. If that's what you want to do, get on with it. Handing it back to you.
That was amazing. Thank you so much. I mean, perfect advice for hopefully all our listeners. Simon, could you tell us a little bit more about how do you see your specialty evolving in the future, perhaps?
So I have the gift of also being old, a bit like a couple of people here. I've had a rather non-linear career, which has given me the ability to kind of look at it from the outside in as well. And it's, you know, reflecting on the question you just asked, one of the things that does get easier is as your career goes on, you start to know what you want more and be less afraid to do it and go for it and fight for it. And again, that's the privilege of just having been around a bit longer. Like, it's an experience thing and an age thing. I think my specialty in particular, I mean, people are looking at all kinds of things. People are looking at robots and stem cells and blah, 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 blah. I still honestly believe that one of the things we're moving towards is just being a more diverse specialty. And I think I'm 100% the wrong person to answer the question, because what you need is diversity of thought. That's the point. Because I'm not going to come up with the new great idea. My argument is that we need to change culture and be more diverse to bring in the people who are going to have the next great idea. It's that stagnation that means we do mostly sort of the same thing. We're still thinking about the best way to hammer a knee replacement in. And we've been thinking about the best way to hammer knee replacements in for ages. It's going to be that new person that has never thought about coming to surgery before who goes, why don't we just do that for arthritis? And everyone goes, oh yeah. That's going to be the game changer. It's going to be that out of the blue thing, because, you know, undeniably, orthopedics is an extremely progressive specialty. We're awesome, and we have multiple different designs of hammers. But a lot of the principles that we're using are principles that have existed for a very, very, very long time. What I'm looking forward to is that game changer. And that game changer is only going to come by diversity of thought.
Thank you so much. And yeah, I think we've all realized how important, you know, diversity of thought is, as well as just diversity in general. And perhaps, Sohaib, if you could talk a little bit more to us about how you see your specialty evolving, because you've mentioned the sort of intense workload, and I know there's a lot going on in ophthalmology, so perhaps you could give your thoughts on that.
Sure. So ophthalmology features a lot of advanced technology, and actually I think this has gone hand in hand with the patient load. So in order to survive, in order to meet these demands, the technologies advance very, very rapidly. In fact, every year there's something wonderful and new. In the future, I think there'll be still advanced technology, possibly artificial intelligence, assisting clinical decision making, but keeping the patient at the heart of everything we do. In terms of the challenges, I agree with all my colleagues on this panel. The challenges evolve as you progress through the ranks. So from the clinical perspective, you gain experience, you practice your surgical skills, for instance, and that side of things can get easier. But you get given more responsibility, a greater degree of independence, and you need to develop good people skills, good negotiation skills, good time management skills. You may be supervising your own juniors, good teaching skills as well. And outside of work, your life evolves, and you may have other demands outside of work, starting a family, for instance. I'm very happily married to a GP trainee for 2 years, and the only way we could live together, as she's in a different deanery, I was in a different deanery, we had to find somewhere in the middle and both commute. And this is sort of all part of your life evolving outside of work as well. The challenges evolve, and really you just have to adapt and make the most of it. And as Stella put very eloquently, enjoy the journey.
Thank you so, so much for reiterating again that amazing advice. I think it's so easy to get caught up in all the stresses and, you know, you're thinking, oh, what shall I do next? What shall I do next? But it is important to enjoy the journey. And Alastair, I'm going to hand over to you to ask the last question before we close.
I think given the time that it is, I think we're actually going to wrap up there. I know that you're all very busy, and we appreciate you giving your time to us like you have today. I'd just like to say a huge thank you to all the panelists. I've really enjoyed some of the discussion points. I've taken a lot from it. What we said about role models, I really liked what Roshana said about ascribed personality types in medicine and surgery, and that's always seemed a sort of, as a junior person, a very bizarre concept. Sometimes I think you have to be ingratiated into the whole thing to even believe that exists, and I think there've been some really important messaging about allying and about people in surgery and things like that as well. So I'm very grateful for the comments that have been made. To our audience, please continue the discussion on Slack and check back on Twitter for some more information about this event and hopefully some subsequent follow-up events that may happen. I'll hand over to Riddhi as well to say what she thought.
Thank you. I'd like to say thank you to all of you as well, and also to all our viewers who are watching. I hope you've really taken a lot from the session. I think what I've taken the most is to, you know, really don't worry about going slow, enjoying the journey. I think it's so important to stand up for your colleagues. I think that's something that really resonated with me, and I hope that you all take this advice and implement it as you are and not wait for anything. So thank you so much to the panel once again, and thank you for our audience, and please continue the discussion on Slack. I'm going to hand over to Johann for our final closing remarks.
Okay, so thank you everyone to the whole panel for joining us and discussing this this topic. Just to reiterate a point Alastair made, if you don't have your question, if you haven't had your questions answered tonight and would like to ask more, make sure you look out for specific Q&As we're going to be doing with some of the panelists over the next few weeks. We'll be posting dates and times on this on the HLA Live resources on Medics Academy and in the virtual coffee space on Slack, as well as on social media via Twitter, LinkedIn, Instagram and Facebook. So like I said, thank you to the whole panel for joining us tonight. I know a lot of the audience have, the HLA audience have asked about the specifics of surgery. However, what tonight brought out for me was how many general lessons there are for careers in all healthcare professionals, all healthcare professions, and across many of the specialties, way beyond the issues faced by surgeons. We've touched on such a range of issues that actually face a lot of individuals that go through healthcare systems. And I listened thinking that whilst the topic seemed very specific to surgery, the reality was that much of the discussion went across healthcare itself. I want to personally thank Riddhi and Alastair and the panel on behalf of the whole HLA community. HLA Live is thanks to the wider team, especially Eamon, Adil, Tim and Pedra for their incredible work delivering the HLA Live programme. We're incredibly lucky to have scholars that want to make a significant impact on healthcare across the globe, and they use the HLA as a platform to bring their incredible ideas and innovations to fruition. If you're interested in the work of the HLA, do make sure to catch a future HLA Live episode, join us at a HLA event, or apply for one of our programs, or apply to become a scholar like Riddhi and Alastair, as well as some of our panelists tonight. Thank you for joining us. I'm Johann Malawana, and it's good night from all of us. Thank you.